Hello, my name is Stormi Gale. I am an assistant professor at the University of Maryland School of Pharmacy and a member of the ATRIUM Cardiology Collaborative. This video will discuss how to optimize beta blockers in patients with heart failure with reduced ejection fraction. It is well established that beta blockers have an important role in the management of patients with heart failure with reduced ejection fraction. These agents maintain a Class 1 recommendation from the American College of Cardiology and American Heart Association to prevent morbidity and mortality in this population. However, it is important to note that this recommendation is specific to the 3 agents in the class that have been shown to improve outcomes in clinical trials. These include bisoprolol, carvedilol, and sustained-release metoprolol succinate. Dissecting landmark beta blocker trials in heart failure is not necessarily the scope of this video. However, being familiar with the benefits of these agents in this population is warranted to understand the importance of optimizing therapy. The 4 major trials of beta blockers in heart failure are CIBUS-2, the U.S. Carvedilol Heart Failure Study, Copernicus, and MERIT-HF. All 4 trials demonstrated significant reduction in mortality with numbers needed to treat as low as 18. Aside from mortality, beta blockers have been shown to reduce morbidity in this population as well. The benefits of beta blocker use often outweigh the risks, and this video will therefore discuss the best ways to optimize their use in this population. There are a few pearls to remember when initiating beta blocker therapy in patients with reduced ejection fractions. First, the patient should be stable. So if the patient is decompensated, it would be best to hold off on beta blocker initiation until the patient is more appropriate for therapy. Starting this class in a non-stable patient can further worsen decompensation. Another common mistake in beta blocker initiation is starting at doses that are too high. It is important to start at the lowest possible dose with plan for slow titration to avoid decompensation. And lastly, patient education is absolutely key in all patients, but particularly this population. It is well known that patients often feel worse after starting on beta blocker therapy, so it's very important that they be educated about the importance of adhering to their regimen, and it should be emphasized that adverse effects like increased fatigue are common and should dissipate after about 2 weeks. Although ideally all patients with heart failure with reduced ejection fraction would be on beta blocker therapy, there are some contraindications to their use. As was mentioned on an earlier slide, beta blockers should be avoided in patients that are acutely decompensated, but also in patients with symptomatic bradycardia or hypotension. And although it's not an absolute contraindication, caution should be taken in patients with heart rates less than 55 beats per minute or systolic blood pressure less than 85 millimeters of mercury. Precaution should also be taken in patients with severe asthma or COPD due to non-selective beta-2 activity increasing the risk of bronchospasm. However, this is most prudent in patients with severe lung disease or acute exacerbations. There are also common misconceptions that concomitant disease states such as depression, diabetes, and peripheral artery disease are contraindications for beta blocker use. Historically, beta blockers have been thought to cause or worsen depression and may be inappropriately avoided due to these concerns. Studies have not definitively demonstrated a causal relationship between these agents and depression, and some have suggested a reduction in depression with beta blocker therapy. There have also been concerns about beta blockers worsening glycemic control and masking symptoms of hypoglycemia in patients with diabetes, but studies have both refuted these risks and demonstrated that diabetic patients with heart failure have a worse prognosis than non-diabetic patients with heart failure, and heart failure outcome trials demonstrated significant benefits in morbidity and mortality with beta blockers in patients with diabetes. Although beta blocker use in patients with peripheral artery disease has been controversial due to concerns about alterations in peripheral hemodynamics, there is no current evidence to suggest that beta blockers worsen walking symptoms in patients with intermittent claudication, and many patients with peripheral artery disease have compelling indications for beta blocker use. It is important to be able to identify patients who may or may not be candidates for beta blocker initiation so that this patient population can receive guideline-directed medical therapy whenever possible. And although it is prudent to start at low doses when initiating beta blocker therapy in patients with a reduced ejection fraction, it is also really important to titrate these medications to target or highest tolerated doses. Titration should be done slowly by doubling the dose no sooner than every 2 weeks. And as mentioned earlier, patient education is of utmost importance. Patients should be re-counseled that they may experience effects similar to after initiation, but that these should similarly resolve with time. Although it is fairly common to see patients with heart failure with reduced ejection fraction on lower than target doses of beta blockers, efforts should be made to up-titrate to the highest tolerated dose. In landmark trials, the mean doses achieved were often near target, with large portions of patients achieving target doses. In CIBUS-2, 42% of patients achieved the target dose of 10 milligrams of bisoprolol daily, and a further 25% had been up-titrated to between 5 and 7.5 milligrams daily. The mean target dose of carvedilol was 37 milligrams daily and 45 milligrams daily in Copernicus and the U.S. carvedilol trial, respectively. In MERIT-HF, 159 milligrams daily was the mean dose achieved with metoprolol succinate, and 64% of patients achieved target. These doses achieved in clinical trials suggest that many patients can tolerate higher doses of these agents, and clinicians should make every effort to titrate up to target or highest tolerated dose when possible. Many patients with heart failure with reduced ejection fraction are not initiated and/or up-titrated on beta blockers due to concerns about borderline low blood pressures and the risk of hypertension. However, it is important to note that patients with low ejection fractions often have lower pressures at baseline. In landmark trials, patients were excluded for systolic blood pressures less than 100 millimeters of mercury for bisoprolol and metoprolol succinate, and as low as 85 millimeters of mercury for carvedilol. In CIBUS 2, there were actually fewer hospitalizations for hypotension with bisoprolol compared to placebo. And similarly, there was less of a decrease in blood pressure with metoprolol succinate than placebo in MERIT-HF. And as we know, there's thought to be a potential for increased lowering of blood pressure associated with the alpha effects of carvedilol, but there were no demonstrated differences in the change in blood pressure in the U.S. carvedilol heart failure study. Mechanistically, slowing the heart rate in patients with a reduced ejection fraction can increase filling time, thus improving cardiac output, which results in unchanged or even increased pressures. Thus, borderline low pressures in asymptomatic patients should not preclude beta blocker initiation and/or titration. In summary, it is well established that beta blockers should be optimized in patients with heart failure with reduced ejection fraction to improve outcomes. As clinicians, we should make every effort to titrate our patients to target or highest tolerated doses. This includes starting at the lowest possible dose and doubling no sooner than every 2 weeks. Patients should be counseled at every visit about the importance of medication adherence and regarding the transient effects of beta blocker initiation and titration, such as increased fatigue. Clinicians should familiarize themselves with misconceptions about contraindications to therapy, and although caution should be taken in patients with lower blood pressures, this is not typically an absolute contraindication to therapy. For more information about the trials and guidelines discussed in this video, please see the citations listed here. Thank you for viewing this video on optimizing beta blocker therapy in patients with heart failure with reduced ejection fraction.